All right, crew, welcome back. So last time we were talking about angina, and we actually had a couple terms in there that not quite sure if have or haven't gone over. So as a little review, let's do those terms, and so that you guys understand exactly what we're talking about when we're discussing this. And it's very important that you understand all of these terms. And by understanding these terms, you're probably going to do a lot better on your National Registry test. All right, so myocardial infarction. Again, myocardial, muscle of the heart, infarction, death and subsequent necrosis of the heart muscle that's caused by an inadequate blood supply. All right, the heart failure. This is a clinical syndrome in which the heart mechanical performance is compromised so that the cardiac output can no longer meet the body's need, okay? Understand that there are two types of heart failure: right-sided failure, left-sided failure. And we're going to go actually into that one on the next video when I'm going to talk about very specifically what is the difference between left and right-sided heart failure. All right, pulmonary embolism. This is a blood clot in one of the pulmonary arteries, one or it could be more, which case it would be known as pulmonary emboli. Next slide would be, if I can get it to go. All right, congestive heart failure. So this is the condition where the heart reduces stroke volume, but it's caused by an overload of fluid in the body's other tissues, okay? So it's actually having to go pump against the pressure that's already there. It reduces the stroke volume. And congestive heart failure is usually caused from either left-sided or can be caused by right-sided heart failure, okay? This presents as edema in certain types of heart failure. But when we usually talk about congestive heart failure, we're talking about the presence of edema, which ends up reducing, and it also has usually has some sort of rail component to it. But that's the congestive heart failure. Pulmonary edema, okay, is when the patient complains of progressive acuteness, shortness of breath, and they confirm being awakened by the shortness of breath. More importantly, rales are usually present with pulmonary edema, okay, whether it be fine crackles sitting up or a very severe crackle at the base. Okay, paroxysmal nocturnal dyspnea. It's usually, this happens when they have shortness of breath and they try to lie down. And it's usually because they have left-sided heart failure and the fluid is essentially back, again, like I said, trying to overcome that. It's not getting enough blood back coming into it, which causes shortness of breath. So that's when they lay down, and that's when that usually happens. Pulsus peristalsis. When the systolic blood pressure drops 10 millimeters of mercury or more when you have inspiration. This is usually a complication that's associated with some sort of pulmonary edema, and it's a compression to the great vessels. When you have thoracic pressure, you're going to have pulsus paradoxus, okay? Now, pulsus alternus, that's when the pulse alternates between being weak and strong, between thready or weak, and then there may be jugular vein distension might be present, and it's also associated with pulmonary edema. So it goes weak to strong, weak to strong, weak to strong, okay? Cardiac tamponade is an accumulation of fluid inside the pericardium. We've talked about that. Again, get them to somebody who can stick a needle in it and drain it. A hypertensive emergency is an acute elevation of blood pressure that requires the blood pressure to be lowered within about an hour's time. I want to stress that part. If you have a hypertensive emergency, usually caused by some sort of reaction, usually causing the vessels to clamp up, and that's why you want to give them something to, an alpha blocker, or you want to give them something to relax or decrease their force of contractions. But we don't want to do it all at once, because the sudden dropping of the blood pressure can actually do just as much damage. So we want to slowly lower that blood pressure to get it down. It causes problems like the hypertensive encephalopathy, renal failure, or any type of blindness. Actually, it can cause this. But what is the hypertensive encephalopathy? Again, that's where you have a cerebral disorder that has several. It's got headaches, nausea, vomiting. It increases the intracranial pressure because there's so much blood being forced up into the brain due to the cardiovascular problem. Okay. Now, neurological symptoms might be blindness, muscle twitches, actually kind of like stroke-type symptoms. And in a way, in a weird sort of way, yes, it actually is that. Now, understand, don't confuse that with them trying to compensate by if they've got an embolus or they've got a blood clot or a blockage, that they're trying to force more blood to clear out that blockage. This is due to the hypertension that's actually causing these symptoms, okay? Again, a very dangerous situation. And one of the biggest questions I get is, well, how do I tell in the pre-hospital setting which one is which? And then the simple answer is we can't hardly, which is why a lot of times in the pre-hospital setting, we don't want to treat a hypertensive emergency unless we really have more data or more information. If I've got a patient that's got a history of it, that had these sudden onsets, and he says, look, I know my blood pressure's gone up, and you take their blood pressure and it's 280 over 100 and 160, yeah, that's something we need to lower. But again, if these are stroke-like symptoms that are coming on, is the person actually having a stroke? So lowering the blood pressure, I would say, would probably say, let's call the doc and talk to them and make sure what they want to do. Cardiogenic shock is the inability of the heart to meet the metabolic needs of the body. Remember, I said cardiogenic shock is one of the three complications you're going to have with an acute myocardial infarction, which means, again, it's a pump problem. It's not pumping. Okay? Remember, in shock, it's either a fluid problem, a pipe problem, or a pump problem. So cardiogenic shock, it falls into that pump problem category. Cardiac arrest is the absence of ventricular contractions. Sudden death is within 1 hour after the onset of symptoms. Downtime, the duration at the beginning of the cardiac arrest until effective CPR is established. So from the time they went down until the time somebody starts pumping on their chest. Total downtime would be between the beginning of the arrest and the patient's delivered to the emergency department. Resuscitation is if you get a return of spontaneous pulse and breathing, and the return of spontaneous circulation is the patient having a spontaneous pulse. Again, the key thing there is between resuscitation and the resuscitation is the provision of effort. So we're trying to bring them back to a return of spontaneous circulation. And then survival, which is, guys, ultimately what we're after. In order to have survival, you got to have ROSC. Okay, you have to resuscitate them to get a ROSC, to get this guy right here, survival, when the patient is going to be able to survive to discharge. Atherosclerosis and arterial sclerosis, a lot of times these terms are used simultaneously. But atherosclerosis is progressive and degenerative of the medium-sized and large arteries, where arterial sclerosis is a thickening and a loss of elasticity of the hardening of the walls. Atherosclerosis is a form of arteriosclerosis, okay? But remember that the atherosclerosis can all, again, they all have to do with the arteries, okay? And what happens is you get calcium buildups, usually triglyceride or cholesterol buildups in there that cause a hardening of those arteries, okay? Claudication, you got pain in the calf muscles due to inadequate blood supply. It occurs either with exertion or subsides with rest. Again, usually it means that you have poor circulation. An aneurysm is a ballooning of the arterial wall. It can happen both in the thoracic. It actually can happen in any artery. But the common ones is where you got a lot of pressure coming off of the heart. Thoracic aorta, abdominal aorta. But again, it can happen in any of them. A dissecting aortic aneurysm is when blood gets and separates in the layers of the aortic wall. It hasn't completely torn the vessel yet. Okay, so that's the good news, is if it is dissecting, if we get them to the surgeon in time, they can graft it and they can repair the vessel break. But again, it's a dissecting aortic aneurysm. Cystic medical necrosis is the death wall of the wall of an artery. Again, this happens usually due to a plaque burst, or the tissue actually dies in that area. Acute pulmonary embolism is a blockage that occurs when a blood clot or other particle lodges in the pulmonary artery. Again, not good. Your acute arterial occlusion is the sudden occlusion of arterial blood flow. Not only in the coronary arteries, but that's any arteries, okay? Can it happen in the leg arteries? Yep. Can it happen in the arms? Yes, it can. So any of these can be an arterial occlusion. Vasculitis is when you get inflammation of the blood vessels. Your peripheral arterial atherosclerotic disease, it's a progression of the medium-sized to large arteries. This is, again, over time. All right? The deep vein thrombosis is it's a blood clot in the vein, and I kind of put it in italics. It's usually in either the upper or the lower legs. That's where they start. Problem is the DVT breaks loose. It goes to the heart, then gets into a pulmonary artery, turns into a pulmonary embolus. Not good. And your varicose veins, these are dilated superficial veins, usually in the lower extremities. Usually very hard, and they look like spider webs for that matter. So again, this is a sign of poor vasculature in the legs. All right, that's going to do it for the definitions, but I wanted to go over those because there's some that are definitely in play with us and what we do. All right, I'll see you guys on the next video.